We have a small live audience and a large virtual audience, and we look forward to sharing with you this episode of Smilow Shares with Primary Care. This is the second year of our series. Dr. Ann Chang, I, and Kevin Billingsley do this cooperatively between our Smilow Cancer Center and Primary Care Northeast Medical Group, which are part of the Yale New Haven Health System. I'm going to put up some slides just to show you where we're going tonight. And this series is a monthly lecture series, and it focuses on the interaction between our cancer specialist and primary care. Our designated audience is primary care clinicians, and the faculty panel always has a primary care clinician in addition to our Smilow colleagues. It's every Tuesday at 5:30, and please join us in real time going forward if this is interest to you, and recordings are always available afterwards as well. We started this series because of a strong desire by primary care clinicians to learn updated recommendations on how to diagnose and follow up cancer and work collaboratively with our specialists. And also because there are a lot of changes that are going on in cancer treatment. And while none of us in primary care will ever actually prescribe a chemotherapy regimen, it is very helpful for us to have a general understanding of what our patients will go through as we are in the diagnosis phase. And we think that's kind of unique in the type of lecture series that we attend. I'm going to start by introducing Dr. Alam, and then I'll pass it over to Kevin Billingsley. I, of course, realize that I didn't introduce myself, so I will do that and have Kevin introduce himself as well. So I'm Dr. Karen Brown. I'm the medical director of primary care for Northeast Medical Group, which is part of the Yale New Haven Health System. And I am thrilled to have Dr. Piyal Alam making his debut in this series. Piyal went to the New York Institute of Technology, College of Osteopathic Medicine, and then did a residency in family medicine at Northwell Health. He started with us at Northeast Medical Group and quickly became a favorite go-to physician for colleagues and also patients in a walk-in in the Greenwich area. And then he saw the light, and he is now a primary care physician and has done that well. He has his office is in Rybrook, New York, which is just over the line, and we consider that part of our Greenwich Hospital network. In addition to seeing patients, and a lot of patients now actively, he also participates in care signature pathways and has chaired some of the care signature pathway work, especially for respiratory infections, and sits on the ID Care Signature Council, in addition to his work in the primary care care signature pathways. And he's part of our pilot group in AMG, which is process improvement leading to optimization and transformation. And I will pass this along to you, Kevin.
Thanks, Karen. I really appreciate being here. I'm Kevin Billingsley. I'm the Chief Medical Officer of Smilow and the Cancer Center. As Karen mentioned, I am fortunate to do this with the real leaders, Karen and my partner, Dr. Ann Chang, who's could not be here with us, at least not at the start of the session today. I am absolutely delighted to have this faculty, Piyal and our Smilow clinicians, bringing this topic forward. You know, as a surgical oncologist, I feel like I know a lot about solid tumor care, but the management of patients with lymphadenopathy, lymphoma, hematologic malignancies is one of the most exciting areas of development in clinical oncology. And, you know, I think regardless of the scope of our practice, our patients will be asking us about some of these treatments, and it will behoove us all to be aware of some of these developments. And it's an exciting topic. I'm thrilled to introduce Dr. Isufi. Dr. Isufi is one of our true stalwarts here in the heme malignancies program. She's an associate professor of medicine. She co-leads the cell therapy research team, and she's the co-leader of the CAR T cell program. And I think Iris will talk a little bit about some of these very exciting therapies in her discussion today. You know, we're fortunate to have Iris here. She went to Stony Brook. She trained at Albert Einstein, and we were able to get her here as a fellow and fortunately keep her on the faculty, where she's had an incredible rise in our organization and does amazing things. It's also a delight for me to introduce Dr. Francesca Montanari. Francesca practices in Greenwich. We were thrilled when about 2.5 years ago, my colleague Ann Chang was able to lead Francesca's recruitment, and we were able to woo her away from Columbia. She is an assistant professor. She is a graduate of the University of Pavia, but did a residency and fellowship at NYU and a research fellowship at Columbia. And she is an active clinician and researcher in the lymphoma space and part of our lymphoma disease associated research team. So true expertise, and I think I'll kick it back to the rest of our team. Thank you.
Good. So Iris, I think you're gonna lead us.
Thank you very much for that kind introduction. So I'm just gonna lead the discussion by talking a little bit about our approach to lymphadenopathy. So in general practice, less than 1% of patients with lymphadenopathy will end up having malignant disease. And this is often due to leukemias in younger children and Hodgkin disease in adolescents. But despite this low prevalence of malignancy among patients with lymphadenopathy, it does remain a cause of concern for both patients and physicians. In fact, for patients who are less than 40 years old, the prevalence of malignancy is only 0.4% in these lymph nodes, and in patients over the age of 40, that rises to 4% in the primary care setting. However, in referral centers, the prevalence rises to 17%, and it soars to 40 to 50% in highly suspicious patients. So when we think about duration of adenopathy, lymph nodes that last for less than 2 weeks, or those that last beyond a year, that do not increase in size, those nodes tend to have a low probability of malignancy. What we consider an abnormal nodal size actually is not uniform for all patients, and it depends largely on the age of the patient and also the location of adenopathy. For example, in children, abnormal sized lymph nodes tend to be over 2 centimeters. And whereas in adults, we think of an abnormal sized lymph node of one that's typically greater than 1 centimeter in its shortest diameter or shorter axis, and then over 1.5 centimeters in long axis. But in terms of location, it is suggested that any palpable supraclavicular nodes, for example, are very highly suspicious for malignancy, or nodes in unusual locations like the popliteal regions or epitrochlear nodes tend to be highly correlated with malignancy, and epitrochlear nodes over 0.5 centimeter, for example, are concerning, or inguinal nodes that are greater than 1.5 centimeters in diameter are considered to be abnormal. So we're just going to go to the next slide. So what is my rule of thumb? Which patients and which lymph nodes do I think about biopsying? So nodes that last more than 2 to 4 weeks in the absence of infection, I'm worried about, and I tend to biopsy those patients. Any lymph nodes that are really rapidly or progressively enlarging over time, are concerning, and I would consider biopsying that patient, or lymph nodes that the radiologist feels may be malignant in nature. We typically tend to order ultrasounds as our first go-to imaging modality, just because we worry about the risk of radiation exposures to our patients. And on ultrasound, oval lymph nodes with fatty hyla are considered to be normal, whereas when the radiologist comments on nodes being round, having sharp borders, lacking a hilum, or nodes that have this peripheral perfusion pattern and lack that hilar vascularity, or nodes that are centrally necrotic, are worrisome for malignancy. And so typically I would think about biopsying nodes that have those features. The other thing that we look at is this, what we call a low long axis to short axis ratio that is less than 2. So if the long axis of node abnormal considered greater than 1.5 and short axis greater than 1, any ratio in those two less than 2, I think about biopsying. And then really any supraclavicular nodes will almost always be malignant. And all of us may remember from medical school, for example, these left-sided supraclavicular nodes, the Virchow node tends to be associated with gastric malignancies, and then lymph nodes in the right supraclavicular area with thoracic malignancies. And that includes lymphomas as well, where you can see either unilateral or bilateral lymphadenopathy. So I put this slide here as just a nice introduction to the significant progress we have made over time. These are 5-year relative survival rates in our patients with blood cancers, including leukemias, non-Hodgkin lymphoma, Hodgkin lymphoma, myeloma, myelodysplastic syndrome, and myeloproliferative neoplasms. This is data from the SEER database and the National Cancer Institute. And as you can see, we've made tremendous progress in all blood cancers in terms of 5-year relative survival rates, going back to the 60s and 70s, and particularly in the last few decades. In Hodgkin lymphoma, we are curing the majority of patients, over 90% of our patients, particularly stage 1 and 2 disease, but also advanced stage patients have relatively high cure rates in the order of 80%. And then for non-Hodgkin lymphoma, we're doing quite well, with 2/3 of patients being alive at 5 years. And go to the next slide.
It's not moving. Right. Let's see if, no. Just gonna put this back up again. I'm very sorry. Just go this way. Okay. All right, so I think we're moving into our first case.
All righty. So first, thank you, Iris, for setting up that excellent foundation for us to work from. It really helps us kind of put into framework our approach that we should take. I really appreciated that slide with respect to the biopsy considerations. And then before we get started, the way we'll start our sessions today is more case-based learning. These cases are based off of real life patients that we've seen, but we have made a few modifications just for our learning purposes. All right, and then so I'll get started. For our first case, this is a very common clinical scenario I've seen. What do we do when we recognize lymphadenopathy after an upper respiratory infection? So we have a 52-year-old female with no significant past medical history, initially presented with URI symptoms and left cervical lymphadenopathy for 2 weeks. Patient's symptoms included classic URI symptoms, nasal congestion, postnasal drip, maxillary sinus pain, low-grade fevers, dark green, brownish nasal discharge, and a cough. Patient was evaluated and treated for a bacterial sinusitis with a course of amoxicillin. After the treatment was done, patient now returns 8 weeks later with concerns of a persistent, non-painful left anterior cervical lymphadenopathy, which has not gone down or changed in size. Patient has now finished the course of the antibiotics, done basic labs during the prior visit, just a CBC and a CMP, which had been unremarkable at that time. Patient now only has a very mild intermittent cough, secondary to a postnasal drip, and has remained afebrile the entire time. However, the patient's main concern is that they're still having that persistent left cervical lymphadenopathy. So from the primary care perspective, there are a few concerns that we may have. One being, what should be the next workup steps? And then also, what should be part of our differential? So Karen, if you wouldn't mind the next slide, please. So from a primary care differential perspective, oftentimes we always think of like a reactive lymph node, right? Especially after an infectious process, maybe bacterial or viral or fungal in nature. However, we should most certainly keep autoimmune disorders in mind. And of course, today's lecture, malignancy considerations. So at this point, I'd like to hand off to Francesca.
Thank you, Piyal. So this is a lymph node that has persisted for 8 weeks after an infection. So certainly the next step would be to start a little bit more workup, and starting with an ultrasound, as Iris pointed out, is a good initial step, because give us like a little bit more information without exposing necessarily patient to any radiation and anything invasive. So the concern, of course, of something that persists in the absence of one of the causes that you listed is that this could be indeed a form of a lymphoproliferative disorder. And what is a lymphoma? It's a clonal disease that originates from immature and mature B and T cell and NK cells. These cells originate in the bone marrow, travel peripherally through the blood and the lymphatic system, and then they're present in the mucus-associated lymphoid tissue and spleen. When we speak about like lymphoma, leukemia, there's a lot of overlapping between these two entities. Leukemia is defined by the presence of these malignant lymphocytes in the blood, whereas lymphoma is when this proliferation happens more in the nodal sites, in the lymph nodes, or even in discrete tissues. And we can, lymphoma frequency and the distribution. When we think about lymphoma, the vast majority of lymphomas are actually non-Hodgkin lymphoma, 78% of them. Hodgkin lymphoma account for 15% of the cases, and T-cell lymphoma are very, very rare. To make things a little bit more difficult, there are more than 60 subtypes of non-Hodgkin lymphomas. And here in these pie charts are reported the relative incidence. The most common aggressive B-cell lymphoma is a diffuse large B-cell lymphoma, and the most common indolent is follicular lymphoma. And both of these two entities account for more than half of all the cases of lymphoma. Non-Hodgkin, T-cell lymphoma are again very, very rare, and there are like a lot of subtypes, and even Hodgkin does not come in one flavor. There are different subtypes, and that's why pathology and initial diagnosis it's really important. We can move to the next slide. The incidence of lymphoma compared to solid tumor these are not as frequent diseases. There are approximately 75,000 new cases of lymphoma in the United States. These are SEER data from 2020, and they're like it's a little bit more prevalent in men than in female, and accounts for 4% of the estimated deaths from cancer in the man population, and 3% in the female population. How do we classify this non-Hodgkin lymphoma? And this is just to give you an overview of the maturation process of the lymphocytes, from the bone marrow to the lymph nodes to the blood in the latest stages. So whenever the cancer occurs during the maturation of the lymphoma, then we have the different subtypes. And we can move forward with the next slide. So in terms of the approach to a patient, it's very important to assess the duration of symptoms, for how long the lymph node has been enlarged. Are there any what we call constitutional B symptoms? And we usually refer to constitutional B symptoms, low-grade fevers, unintentional weight loss, night sweats, pruritus. Has there been any environmental factor like that could have posed a patient at risk for lymphoproliferative disease? And we think about chronic infections, autoimmune diseases, exposure to chemicals and radiation. Ethnicity and place of birth plays a role because there are certain areas where certain viruses are endemic, and there are certain viruses that have been linked to specific subtype of lymphoma. And then we also get a good family history, because although there is not genetic predisposition, certain types of lymphomas in general happens more frequently in certain families than you would expect just based on the incidence of these diseases. A number of siblings help us thinking like ahead in case this is something we need to consider for a transplant. In terms of the exam, it's very important to assess for lymph nodes, but also for hepatosplenomegaly. Skin can be involved, and a neurological exam. There are certain lymphomas that have a propensity to involve the CNS. In certain patients, we do also a testicular exam, depending on the suspicion of the kind of lymphoma. And in terms of imaging, PET-CT is a sort of the gold standard for the staging of lymphoma. It's a much more detailed than a CT scan, because it gives us not only the anatomic distribution of the disease, but also the activity, so the metabolic activity. And that is a really good indicator on how fast the lymphoma is growing. And it might pick up lymphoma in areas that are not necessarily abnormal. In terms of laboratory, and that's something that can be initiated even in a primary care setting, if there is a patient that has a suspicion for a lymphoma, it's always good to get a very broad set of labs, including, of course, the complete blood count with differential to assess for lymphocytosis, the presence of abnormal atypical lymphocytes in the blood, a comprehensive metabolic panel, an LDH, which we use as a surrogate marker for growth, a uric acid. There are certain lymphoma that might be so aggressive at the beginning that they might cause even spontaneous tumor lysis even before starting treatment. SPEP and an immunofixation is always helpful, because the more it's differentiated, the lymphocyte, when it becomes a lymphoma, the more it retains, or it has an ability to produce immunoglobulin, and gets very close cousin to maybe a multiple myeloma, such as marginal zone lymphoma, lymphoplasmacytic lymphoma. They have a marker, and we can and that would substantiate the suspicion. A SAD rate, inflammatory markers in general, and then we check a lot of viral serologies and PCR, as viruses have been implicated in the pathogenesis of many types of lymphoma. Risk factor for lymphoma.
Francesca, before we move on, would we be able to go back to that last slide 1 second? I thought that was a very powerful and excellent slide, especially from the primary care perspective, how we could provide some support, especially with respect to the exam component, being mindful to check all areas for lymphadenopathy, not just the area that the patient may be complaining about. And also the neurologic exam, that was another part that really I thought was very powerful as well. So again, thank you for that. Is there any particular tips or tricks that you have with respect to things to look out for the neurologic perspective or the rashes?
I think that a really thorough whole body exam to dermatological manifestation. And in terms of neurological exam, sometimes, I mean, if you have an aggressive lymphoma, you can have a really, really dramatic findings at the neurological exam. But sometimes it's a little bit more subtle. It could be just a peripheral sensory neuropathy, and that could be associated with having a monoclonal component, having a monoclonal spike, having a prior protein, or if there is any or concern about like something compressing in the spine. I think that when we think about lymphoma, the first thought is like lymph nodes, but it's much more than that. It's a disease that travels with the blood, so belongs pretty much everywhere to the body.
Thank you.
In terms of risk factor for developing lymphoma, so these are cancers of the immune system. So anything that triggers the immune system can be a setup for a lymphoma. So infection, viral, bacterial, there is a long list of viruses and bacteria that have been associated with the development of certain forms of lymphoma. Immunodeficiency, which could be a congenital or acquired, and HIV status being an organ recipient, but even being on immunosuppression for a rheumatological disorder. And then certain exposure, of course, to toxins, so benzene, herbicides, radiation. These are all risk factors. Maybe we can. So how do we diagnose lymphoma? In order to make a definitive diagnosis, we need a tissue biopsy. And that could be, we favor an excisional or a core biopsy if an excisional is not possible. An FNA is really not, is really suboptimal. It's not something that we should base our diagnosis of lymphoma on. Because it won't allow the pathologist to appreciate the architecture. And as we hinted at the beginning, there are so many subtypes of lymphoma, and really we really need to have a comprehensive evaluation of the, ideally, of the whole architecture of a lymph node. There are certain tests that we do on the liquid phase, so that it can be done on an FNA. And the flow cytometry is the most common test. It's a very good initial test, but again, does not and help us, especially for certain types of lymphoma. B-cell, non-Hodgkin lymphoma can be, clonality can be demonstrated by flow cytometry, but that's not true for T-cell lymphoma. And especially for Hodgkin is really a suboptimal, does not really help at all with the diagnosis. So morphology usually is like immunohistochemistry, and then there are cytogenetics and molecular tests that help us narrow down the diagnosis. We can move to the next slide, which is imaging studies. I just included here a comparison between the information that we can gather from a CT scan, which essentially gives us the size and the anatomy of the various organ, and a PET scan where we use like fused imaging between the metabolic activity and the size of the anatomy. And we measure the metabolic uptake using this standard uptake value, the SUV activity. The lowest is the activity. The lowest, the more indolent is usually the behavior of the lymphoma. The highest is the SUV activity. The more aggressive is the lymphoma. And there is a good correlation between SUV usually and the proliferation rate that we measure on the tissue biopsy. So ideally, in somebody that has a lot of lymph nodes that line up with a PET scan, we would go for, we would attempt to biopsy, to get an excisional biopsy of the hottest one, because that would be the most likely involved by the lymphoma. And if there is any high aggressive feature, it would be in that spot. And we would like to know about it. We can move on to the next slide. So based on the case that Piyal presented, this is a lymph node that persisted over 8 weeks after the after an infection and does not have any aggressive features, so most likely to represent an indolent form of lymphoma. And what is our approach to indolent lymphoma? We don't necessarily treat patients just based on a diagnosis of indolent B-cell lymphoma. These lymphomas are usually not curable, and there is no advantage in starting a treatment earlier. We reserve treatment to specific cases when the burden of disease is significant, and we use this GALF criteria that sort of to as guidelines, so having more than 3 lymph nodes greater than 3 centimeters or a very large lymph node over 7 centimeters. If the patient has symptoms, if the patient has splenomegaly and early satiety, if the lymphoma is growing in area where it's causing trouble, hydronephrosis, pleural effusion, or ascites just from compression, or if it is causing cytopenias from the bone marrow infiltration. If the patient does not meet these criteria, our approach is watchful monitoring, and there are patients that we watch for many, many years before they require treatment. In certain specific cases, when there is a lymphoma that is associated with an underlying infection, we might select to treat the infection first, and that's true for gastric malt, where that is Helicobacter pylori positive. We might start with antibiotic treatment before considering radiation. In certain cases of marginal zone lymphoma, we might consider treating if there is an active hepatitis C or other form of infection, and there is a long we can. Okay. So another option, if the indolent B-cell lymphoma is very limited stage, would be radiation therapy, but these are very rare cases. Otherwise, we consider a combination of immunochemotherapy, and we treat patients as needed. We can move on to the next slide. And
again, something happened and it's not moving. Let me go again.
So Piyal, do you want to? I think you're muted.
Sorry, yes. So how should primary care follow up after treatment and monitoring? Again, I'll let you briefly just give us a quick update on that.
Sure. So in case of indolent lymphoma, as I mentioned, these are not form of lymphoma that we think we can cure. These are patients that might require intermittently treatment, and they might have a very, very long period of time where they do not require treatment, where we sort of like see them every 6 months to a year. So it's very important to partner with their primary care physician to keep a closer eye on them, especially if these are patients that we would like to bring back. Of course, if they develop any new symptoms, if there is any new enlarging lymph node that is noted at the exam, or if there is any abnormality in the either complete blood count or in the chemistry, because unfortunately relapses can happen in these patients a very long time after their initial diagnosis, and so these are patients that should that we sort of don't graduate from our clinic after the end of the treatment.
Francesca, you're absolutely right, especially with respects to our physical examination and history with these patients is so important from the primary care perspective. Even looking out for those more atypical type of symptoms and things like that, keeping that in mind, the B symptoms, very important. And now we'll be moving on to case number 2. So I'll read this. So for our case here, we have a 45-year-old female with a past medical history of rheumatoid arthritis on immunosuppressive treatment, presents with lymphadenopathy in the left axilla, enlarging progressively over the past 2 weeks. Patient noticed a significant increase in size over the past 2 days, which had prompted the initial visit. So our patient has no significant past family history or cancer history that we know of, but the patient is on immunosuppressive treatment. So with that in mind, I'll request Iris take over.
Okay, great. So how can we narrow down the diagnosis in this patient, and what are some of the risk factors that can predispose some of our patients to lymphoma? So we have a young female, 45, with axillary adenopathy. I mean, one of the first things I would like to know is, is it localized or is it generalized? And how has it changed over time? When we think about lymph nodes that are waxing and waning in nature, getting bigger and then getting smaller, those tend to be more consistent with low-grade lymphomas. Aggressive lymphomas typically will present with lymph nodes that are rapidly enlarging over time and that patients become symptomatic from in terms of having drenching night sweats or unexplained weight loss. So in this young female, the other thing I'd be looking at is for any abnormalities in the associated breast. Is there any evidence of infection, mastitis? Could there be an underlying mass that may be consistent with breast cancer? Is there any evidence of inflammatory breast cancer with skin thickening or nipple retraction or discharge? Is there an underlying silicone breast implant, for example? There is a risk of ruptured silicone breast implants in certain kinds of lymphomas, particularly T-cell lymphomas. I want to know if this patient has an underlying history of cancer, particularly any small resected melanomas. We know that melanoma is one of the great imitators that can present with relapse in the forms of adenopathy years after the initial resection. I want to make sure we exclude infection first in the patient. So is this perhaps a patient that may be overweight, that may have suppurative lymphadenitis? Is there any evidence of infection in the hand, cat scratch disease, any point of entry, a zoster rash, or in a patient from a TB endemic area, scrophaloderma, for example? We ask all our patients for any underlying HIV risk factors, whether they've had a history of solid organ or stem cell transplants, because those patients are on immunosuppression, and we do see post-transplant lymphoproliferative disorders, and aggressive lymphomas, particularly diffuse large B-cell lymphoma, is one of the most common subtypes of lymphoproliferative disorders. And then we also try to elicit a history of any underlying rheumatologic conditions, because we do know that those increase the risk over that of the general population. This patient has rheumatoid arthritis, and we know that lymphoma risk is 2 in 50 or 4% compared to 2% in other US adults. And then also we look at certain ethnic groups, for example, patients of people of Ashkenazi Jewish descent may have been enriched in BRCA1 and 2 mutations, risk of breast cancer, triple negative breast cancer in young Black American females. We try to get a very thorough family history in terms of breast cancer, for example, or lymphoma in the family, or any underlying genetic conditions. There are not many that are associated with lymphoma, but Li-Fraumeni syndrome, for example, with TP53 mutation, is an autosomically dominantly inherited syndrome that spans a variety of cancers, including lymphoma. And then any history of travel for this patient or any medications, although those tend to be to present with more generalized adenopathy. So did the rheumatoid arthritis play a role in this case, or the treatment with tofacitinib in this patient? Certainly RA, as I mentioned, increases the baseline risk. And over the years, there have been a number of studies looking at the role of biologic therapies. And initially, there was a lot of data with methotrexate and TNF inhibitors showing as high as a 3-fold increased risk of cancer and lymphoma in these patients. However, more recent large studies have shed some more light, and they seem to show that patients who take a biologic tumor necrosis factor inhibitors or other DMARDs do not have an increased risk for lymphoma over the background risk associated with an underlying rheumatologic conditions. But in general, in RA, there's this inability to control unwanted inflammation, or these patients have this loss of tolerance that may be directly connected to their inability to survey lymphoid organs for neoplasms and to suppress the outgrowth of these malignant B-cell clones. And with tofacitinib, there may be a very slightly increased risk over for background. So I suspect that's what predisposed this patient to the development of lymphoma. So next slide. So what should our next workup be? Blood work is very important. CBC and a comprehensive metabolic panel with tumor lysis markers, like Francesca mentioned, LDH, uric acid, phosphorus. We do check for HIV in all of our patients that we suspect lymphoma, because treatment with retroviral agents in HIV has shown to improve outcomes with chemotherapy and other cancer-associated therapies. And we also check them for underlying hepatitis B or C, because patients who have had exposure to Hep B, for example, are at risk of reactivating that virus, even if they're only core antibody positive, and we do put them on antiviral prophylaxis with agents like entecavir or lamivudine during treatment with chemoimmunotherapy. The next step would be to get a plain chest X-ray and see if there's an accompanying mediastinal mass, and then get a CAT scan of the chest, abdomen, and pelvis in this patient to look for any evidence of adenopathy elsewhere if the chest X-ray shows a mediastinal mass. If it doesn't, usually it will lead us to the route of getting a mammogram, and then if any abnormality is found, that patient would be referred to a breast surgeon for a biopsy and sampling of the axillary node. But if there's concern for more, then the B symptoms are weight loss greater than 10% of body weight over the preceding 6 months, fever that's over 38 degrees centigrade unrelated to any infections, and drenching night sweats. Fatigue is, as many people at the end of treatment, and having a score of 5 would lead you to rebiopsying the patient. Okay, next. And then in terms of other sites, you might see this in primary care, that patients will have enlarged lymph nodes, but at the same time, they may present with CNS symptoms, particularly true for patients with HIV, patients with Burkitt lymphoma, or patients with large cell lymphoma that have multiple areas outside of lymph nodes of involvement. Those patients are at risk for CNS disease, and you will literally see them losing cranial nerves with every 24 hours that go by. So they need urgent lumbar puncture evaluation and immediate referral to oncology. Typically, they will have constitutional symptoms, high LDH levels accompanying that presentation. And then skeletal imaging we get for patients who come in with bone pain, and we suspect fracture or impending cord compression. The other thing I wanted to point out in this slide is that we often neglect to do a testicular exam in males, but up to 10% of patients at diagnosis will have involvement of the GU tract. And in males, that is could be the primary site of lymphoma initiation. It could also be a sanctuary site that can later on lead to a CNS relapse, because it is a site that chemotherapy does not penetrate well, and we manage that either with orchiectomy or radiation therapy. Okay. So then the next step would be to get some functional testing. We do get cardiac function testing in patients because most of them will end up getting treatment with anthracyclines. And then we look at their age, but not so much the chronological age, but the biological age. I have treated and cured quite a number of patients in their 90s with aggressive lymphomas like diffuse large B-cell lymphoma. And then there are younger patients who are chronologically younger but more frail and may have more comorbidities who may make it more challenging for us to treat. Diabetes, for example, is a major comorbidity because most of our patients with lymphoma end up needing steroids at one point or another. And that is one of the areas where I collaborate very closely with their referring primary care physicians to manage their hyperglycemia, particularly around the time when they're taking steroids. Okay, can go to the next slide. So this slide looks at the International Prognostic Index that tells us what our patient's 5-year overall survival is for aggressive diffuse large B-cell lymphoma. And I put this slide here just to show you that patients who had very high risk factors in the older days when chemotherapy only was available had a 5-year overall survival of only about 25%. But in 1997, we had the first monoclonal antibody, rituximab, targeting CD20, this protein cluster of differentiation protein on the surface of the lymphoma cells. And that has made a huge change in the 5-year overall survival, which has doubled to 55% for the poorest risk group of patients, and then to above 90% for patients with very good risk factors. Okay, next slide. So the treatment for diffuse large B-cell lymphoma will typically be a backbone of CHOP chemotherapy in combination with rituximab, which can be abbreviated for stage 1 disease to just 3 cycles. But for more advanced stage disease, we typically give 6 cycles of chemotherapy. And I've shown you the progression-free and overall survival curves to the right of the slide, which have really doubled with just the addition of rituximab to CHOP. And then for recurrent disease, we have a number of salvage chemotherapies different from R-CHOP that we can use. And we typically consolidate that response with high dose chemotherapy and autologous stem cell transplant using patients' own stem cells. And then in some patients, who are not sensitive to chemotherapy, we are now using T-cell therapy that's genetically modified to target the lymphoma. Okay, go to the next slide. And this is just to show you that in addition to our chemotherapy and targeted therapy armamentarium, we now have a multitude of antibody drug conjugates that and bispecific antibodies that, in addition to targeting molecules like CD20 on the surface of lymphoma, will also engage the immune system, will engage the patient's own T cells to come to the tumor and assist in killing the tumor. And then T cells that are genetically modified and are these like super strong T cells that have very strong signaling inside them to proliferate and result in very high tumor kill. Okay. And just a quick word about HIV lymphomas, diffuse large B-cell lymphoma and non-Hodgkin lymphoma in general is an AIDS-defining illness. DLBCL is the most common type, but importantly for us, data has shown to initiate antiretroviral therapy in all patients because they have better outcomes, better survival, and that these patients are at risk for more cytopenias, so they do require very good prophylaxis and support for infections, but they do very well in the long term. We can give them the same treatments that we give patients without HIV, including stem cell transplants, as long as we provide the appropriate supportive care measures for HIV control. Okay, go to the next.
Well, we have had technologic failures today, some interrupted network, and my slides stopped showing. And I think we were just at the end of this second case. I don't know if we want to say any more about that, and we should probably wrap up at this point. Are there questions amongst our panelists or those listening?
Yeah, Iris, that was an excellent presentation. Especially, I appreciated when you're talking about the workup steps with respects to the lab work and the imaging, what to consider. I feel a lot of primary care clinicians think, what should we do? Should we get a chest x-ray? Should we do an ultrasound mammogram? I think having the confidence to put in those orders while we put in our referral, hopefully urgently we could get it, but be able to collaborate with our oncology colleagues, that would be ideal. So really, I really appreciate that slide, and I'm probably going to be going back to it again as well.
Well, that's why I think forums like this are very important, you know, where people participate, because we get to know and meet each other, and you know, we're only a phone call away. So this is a great way for us to get introduced to primary care and to meet all of you, and for you to meet us.
Well, and thank you so much. It is true, familiar faces and relationships make good care. So thank you so much for your careful presentation. Anne Chang, I had no idea that she was the one that always made the slides work and the recording not stop and have to start again. You know, I didn't know she was doing anything technical, and she might not either, but somehow in her absence, we did have some technological issues, and I beg your forgiveness, and to those who were listening. But thank you so much for a great session, everybody. And if you can stay on, there is those listening, there is a slight evaluation afterwards that'll just take a minute. Good.
Thanks, everyone.
All right.
Thank you.